longer. That's why there's 3 technical lecture blocks for the 2 slideshows. We will not rush through it. But we'll finish this out real quick, and then we'll get into the abdomen stuff. So we left off last time looking at the anterior masses, or the mediastinal masses of the thorax. Told you kind of how to focus on that. The only one that you're really going to focus on as far as x-ray goes is I need you to understand that in your middle masses, lymphadenopathy, I told you had to cross it off on that anterior one, right? Because that was supposed to be lymphoma and it was a typo, so I had to cross that off because this is where it is. Lymphadenopathy is the most common mass in the middle mediastinum, okay? Most common mass. Other malignancies could be small cell carcinoma, metastatic disease, right? Well, metastatic disease can go into the lymph nodes, so it can cause some of that lymphadenopathy as well. It makes sense. That's the immune system factory. So when there's malignant stuff there, it's going to rev up. It's going to look like a mass on the x-ray. Benign masses, look at that. Infection, viral, bacterial, fungal. So you're like, great, I could have cancer or I could have nothing. It could just be benign. That's why that bottom line in that bold area, right? Like I said, any of these masses in the mediastinum, the x-ray is your initial study, because you don't know what's going on, you're going to see it, and then as soon as you do, what are we jumping to? CT. CT to further evaluate it. Figure out what the heck it is it attached to something, because I can't tell you on this middle picture where the white arrows are, I can tell you that's a widened mediastinum compared to my normal, but I don't know where that mass is attached to, where it's coming from, right? Is it lymphadenopathy? Yeah, maybe, because it says it's most common mass in this compartment. But could it also just be a viral infection, right? Or a bacterial infection? Yeah, it really could. And that's where the CT comes into play here to really kind of tell us, is that something that shouldn't be there? Or is that just inflammation, fluid, what's going on? And then posterior masses, right? Biggest thing here is look at your lateral. I'm going to draw this one right here. So we had the picture before with the posterior masses. You can see it. And what is it encompassing over? The spine, right? Your posterior masses, if we go back and look at the other picture we had this as like your posterior compartment. Posterior masses are always going to be over the spine, which makes sense why they're considered the nerve sheath tumors, right? Schwannoma is what they're going to be called for the most part. They are benign tumors. You're going to learn more about that in neuro. I'm not going to get too hung up on it here, but just understand that if you're seeing masses in the posterior area, CT to further assess still, because I need to know that's a mass, and that's not just a consolidation, right? It's not just inflammation, it's not just fluid, it's an actual object that's sitting in there. I won't know that unless I have a CT, right? So then what are these things that are going to concern us about that? Well, what are their symptoms? If they're having a cold, if they have cold-like symptoms or flu-like symptoms, then maybe I don't need a CT because maybe it's probably a pneumonia or something along those lines. I'm going to treat that first, right? But if they're just coming in and they're not having any of those symptoms, and especially if they're having any of that unexplained weight loss, fever, night sweats, those things that make you think tumors, cancers, bad guys, then I'll probably jump to a CT on this, okay? So if we know that posterior masses, we look at it over the spine here, we know they're neurogenic tumors, typically, that's usually what they are, then what other area in the thorax do you think we might find these things if they're neurogenic tumors? Besides over the spine, right? Think back to our pneumothorax. What's our treatment for a pneumothorax? Chest tube. When we're putting the chest tube in, what are we always watching for? Where are we putting it in? Where are we feeling and putting it in there? Over the top of the rib. Why over the top of the rib? Nerve, artery, and vein underneath the rib, right? And that neurovascular bundle on the inferior aspect of the rib. So what you can see sometimes is rib notching for some of these neurogenic tumors. It almost starts eating away at the bottom part of the rib. Why always inferior? Because that's where the nerve sits, right? So that could be another one of your signs. If you start to see these erosions, so here I got a good rib, that one's okay. I can follow, kind of trace my cortex okay. But then here I come up and it kind of looks like that. This one here kind of comes up and back down and looks like that. This one's kind of like here, right? And so you start to see those inferior erosions of the ribs because that's where that neurovascular bundle's at. So if you happen to see this incidentally on x-ray, this would be your concern to kind of go, hey, I got what they call ribbon ribs, right? It's got that wavy appearance, looks like a ribbon blowing in the air. Go back to old school Will Ferrell doing the dance, little ribbon in the air, right? Ribs should be nice and clear, but it doesn't look like that. Then we're probably going to get a CT on this patient too to further evaluate what's going on with those ribs. Are there masses there? What's the story? You'll learn more about that in neuro, but this is just some of the imaging findings that would lead you to think of schwannomas or other types of malignant tumors that are in the neurovascular area. Yeah?
So for the other masses that were on the spine, why were they a lighter versus darker on this one?
Say that again.
Okay, so that's radio.
Opaque.
Yeah, so why would they not be radio opaque on the ribs then too?
Oh, that's a good question. I don't know that answer, right? Because what's happening with this one is a lot of from what I know from neuro, from talking with Colonel Rogers, who's talking more about him, a lot of the tumors that go on underneath those ribs would be more kind of lytic. Remember how we talked about earlier the lytic lesions versus the osteoblastic lesions? We talked about radio-opaque versus radiolucent. The ones that are more common, and I don't know the names of them or anything, underneath the inferior ribs are more lytic type tumors and lesions. So that's why it eats away at the bone instead of producing. The difference between this guy and the other one is the other one was a mass that was just like sitting in the posterior compartment, not actually on the spine that I saw on the, at least I could see on the x-ray, but then these ones start eating away at it. And the next slide kind of shows what I'm talking about with the CT. So you can see how some of these lesions, this one actually is eating away, but now look at what's happening with my spine, right? It's starting to eat away there, but I still have tumor within the spine. So you're not really gonna notice that part of that is missing without having that axial in the CT. But if I had one just sitting like on my rib here, that's gonna be more noticeable if the rib is missing, just the way the x-ray works. Because again, in the center, we have all this stuff, right? That's kind of hard to kind of make out that the inside of my vertebral body is being eaten away by a potential lytic cancer. But ultimately, what you need to know is if you see this, you're going to get a CT to find out if this is what's going on or not, and to further evaluate. You'll get more in oncology, more in neurology about some of these kinds of things. Okay. Here's an example where there's the lytic lesions, right? And it's starting to eat away here at the inside of the vertebrae, or it's actually in the spinal canal and it's eating away that way. This is where the CT shows it a lot better than the x-ray does. And this is why we jump to that CT. On x-ray, on this far right one here, you're not going to notice that vertebral body kind of missing because although it's been eaten away, there's a mass and a tumor sitting behind it. So radiation just gave it shadows, right? There's still something there. So you wouldn't notice that on x-ray that it's being eaten away. You would notice the increased radio opaqueness because that's a lot thicker than what it should be when you put in the soft tissue and the bone. So you may end up noticing that primarily on the lateral or even the AP, and then you get the CT and then you see it. So. Biggest thing, right? This is the slide you gotta take away from it. All mediastinal masses, often found on chest x-ray, often incidental findings. You find the lining in that mediastinum, and then what are you gonna do? You're gonna order a CT. You need to further evaluate from the CT, right? Unless it's a thyroid mass, well, you're still gonna get the CT, but if it's a thyroid mass on CT, then you jump to either radioisotope thyroid scan or thyroid scintigraphy, same concept, to further evaluate that goiter and that thyroid mass. Every other mass, the CT is gonna pretty much get there what you need to know and determine whether or not you need a biopsy or not. But the thyroid one, you take that next step, if it's confirmed that it's a thyroid, to figure out cold versus hot, that kind of thing. This slide right here, this is what you need from the mediastinal mass section. This is what you need to know. Questions on anything about the chest, period? I know that was 5 lectures on the chest, but can you think of anything on the chest that you want to hit before we start jumping into abdomen? Okay. That's it. After this, no more chest questions, right? I'm not going back. If it comes up, let me know on the break or save it for the Q&A review that we're going to do. Time TBD, depending on what happens with your schedule and everything. But now we're going to jump into the abdomen. I know you've covered some abdomen stuff in pathology, so now we're actually going to teach you what pneumoperitoneum is and what happens when there's free air under the diaphragm and all that other kind of stuff. What you're gonna see a lot of is that X-ray again is our initial study, but CT a lot of times is gonna be our study of choice, except for in certain areas, so start paying attention to that, because certain things are ultrasound instead of CT, and we'll take a look at that, all right? What we have here, does anybody know what the black arrows are showing? Stuff, right? So what this is a female patient, and you're not gonna know just from the picture, okay? This is actually a uterine fibroid that's sitting right here. So it's a fibroid on the uterus. You'll learn more about that in Women's Health again. I say that a lot, but you will. So this here, where this arrow is showing, is the main uterus. This area here. This is the fibroid. Okay? Now, is CT the study of choice to evaluate the uterus for everything? No. So they likely did not order this looking for a uterine fibroid, because that should have been what type of modality? Not MRI. Ultrasound. Okay? Can MRI be used? Yes, but is it the preferred modality? No, it is not. Ultrasound. Cheaper, faster, right? Don't have to worry about any type of really contrast allergies, don't gotta worry about any type of metal, right? And you can get in a heck of a lot sooner, right? I can get into an ultrasound for about 2 weeks in most places at the longest, let alone 3 to 4 months for MRIs, depending on what's going on. So, and it's a pelvic organ, so ultrasound. So this was an incidental finding, not what they were looking for. All right, so it says 4 hours, 4 to 4.5, maybe 5, right? We're gonna talk about GI imaging, GU imaging. Here is your vocabulary. Haustra, valvula conventae, that's the only time I won't say that, I'll say that a lot. Valvula conventae, and these are important because this is how, these two things are how you're gonna be able to tell on an x-ray, large bowel from small bowel. You can tell, especially in the abnormalities when they're distended and we look at it, there's air in it, based off of whether or not you see haustra or you see valvular conventae, you will be able to tell small bowel versus large bowel at the end. We'll talk about diverticula specifically, and what happens when they become inflamed, and what do we call that, what does that look like. We'll talk about things like sessile, pedunculated, and then the phlebolytes, the fecaliths, appendicoliths, all those things. We've already talked about phlebolyts a little bit. We'll show them some more in here. But here we go. So, in general, right, plain radiograph indications. Look at that. Everything. Trauma, pelvis only typically, because we're looking for that unstable pelvis, right, like we talked about. Make sure is it stable, is it not stable? Any type of abdominal pain, people are going to get an x-ray. Do you want to guess how often an x-ray shows you why the abdominal pain is happening? Almost never. But it is still the first step of imaging because it's cheap, it's fast, it's easy, it's not a whole lot of radiation, and it might actually give you the answer that you need, right? If they're severely, we'll say if they're FOS or severely constipated, you can see that on an x-ray, right? And you'll be like, oh, well, here's the problem. You just need a laxative, right? If they're distended, if there's small bowel obstruction, if there's something called ileus, we're going to talk about all these things. You can see it on an x-ray. So this is why we jump to an x-ray first. It's quick, easy, and might give us the answer, right? Abdominal distension, yep. We'll evaluate for kidney stones and gallstones. Are we often going to see kidney stones or gallstones on x-ray? Probably not. Probably not, but we will still do the picture just to make sure, right? Stone progression, we put stents in. Really, I want you to focus on the right side. What are we looking at? What are we going to be evaluating? Guess what? We have a systematic process on this too. You're going to be looking at your bowel gas patterns. We're going to talk about what normal looks like. We're going to talk about what happens if the patient is upright or supine. You're going to look and see if there's any bowel obstruction. You'll look for the stones. You can see the organs usually really well, especially on the smaller patients. Smaller the patient, the easier it is to see those organs. We'll look for free air and foreign bodies. Remember on that bottom part there, often this is the initial study, but very rarely is this the definitive or study of choice. Very rarely, okay? Now, we don't always need the study of choice to get our answer, right? But if I ever ask study of choice on a lot of these things, it's very rarely going to be an x-ray, a plain film x-ray for the abdomen. CT, often the study of choice, right? We'll do it for trauma. We can do virtual colonoscopies, abdominal pain, vascular concerns. I like this word there. Almost anything and almost always with contrast. There are very limited situations when we're doing a CT of the abdomen without contrast. We will talk about those. If I don't say CT without contrast for the rest of this block, for the abdomen, you can assume it's with contrast. Okay? If I don't specify we don't use contrast and why we don't use contrast, kind of like what I did in the first block with the head CTs, I explained why we don't use contrast and why it would negatively affect it. If I don't take the time to describe that, any CT we're talking about for the abdomen is going to be with contrast. Tracking? Okay. I think it's on most of the slides, but there might be one or two where it just says CT. Unless it says non-con, it is considered with contrast. Okay. What can we see? We can see all those things. We're going to talk about a bunch of it, right? Rupture, perforation, colitis, cancers, appendicitis, potential vascular disease, ureterolithiasis. We always say kidney stones. We're really looking for ureteral stones. I don't care if the stone is sitting in the kidney because guess what? It's not causing any problems yet for the most part because it hasn't gone down to the ureter. When people come in with pain, it's because that stone has moved to the ureter and it's dragging across that ureteral wall. But we'll take a look, and that's without contrast. And then lots of other options. So let's talk about the CT. You've seen this before. There's oral and IV contrast, right? The idea is if I give IV contrast, what am I highlighting? Vasculature, right? To include the organs, because the organs have blood flow, right? So it highlights the liver, the kidneys, the pancreas, the spleen, all that good stuff, okay? How do I see what's going on the inside of the intestines? Blood flow gonna go to the inside? Nah, it just covers the outer walls, right? So I gotta do oral contrast if I want to evaluate the small intestine, right? The stomach, that kind of thing. Large intestine, we don't do oral, we'll do rectal contrast, called a barium enema, we'll talk about that. Because if I had to wait for them to drink and for it to go all the way through, right? What does the large bowel typically do with fluid? Reabsorbs it. So I'm not gonna have them drink this liquid and have it go through the small bowel and then wait for it to go all the way through the large bowel. No, that's gonna take too much time and the odds are it's gonna start reabsorbing some of that. It might not be a good picture. So we just do the barium enema, do the rectal contrast, fill their large intestine up with barium, take my quick x-rays, my quick picture, take it out, drains, hydrate them, and they'll be good to go. But we'll look at what some of those pictures are. But usually when you see CT with contrast, a lot of times it's both, right? IV and oral, when I'm worried about the stomach, because I want to look at the abdomen. Now, if you're in the ER, they usually forego the oral contrast because it takes 2 to 3 hours sometimes to drink this stuff and get it to where it needs to go to get good pictures. If I'm in the ER with abdominal pain, you think I really want to sit on this patient for 2 to 3 hours if there's something emergent might be going on? No. You're just going to get the IV contrast, get as good of a look as we can, and go from there. But when you're out in your outpatient facilities and you're seeing patients in your regular outpatient clinic, and if you feel the need to order a CT abdomen, right, for any of their conditions, order it with oral and IV. Because what they're going to do is they're going to go schedule their CT, and their CT is going to be next Tuesday at 1400, right? And they're going to be given their oral contrast, and they're going to take it home. And they can start drinking it at 9 or 10 or whatever their instructions are. So by the time they come in, it's where it needs to be. They get their IV, they get their scan, they're in and out in 5 minutes, right? So outpatient, you want to order it that way. If you're in the ER, you're probably just going to do the IV and just push them that way. IV, iodine base, right? Oral, rectal, barium base, cavity space, iodine base. We've seen this slide before. And this one, don't. Right? I won't have well-controlled diabetes on this one. Don't do it. But please do pay attention. It's important. Because if you're in an outpatient setting, you want to make sure they're off those nephrotoxic medications, but you still, regardless, need to make sure they're not having any kidney issues. If they have kidney issues, you can't give them this iodine contrast. It will zap their kidneys. All right? Okay. There you go. Have you guys learned about serum creatinine yet in Clin Lab? Right? This whole thing stemmed from the fact that last time from the first block, that question used to just be a bunch of lab values, and it gave you a bad serum creatinine. You were supposed to pick that out as the thing to be concerned about. But you guys hadn't gotten there in Clin Lab yet, so I was like, well, I can't give them that because they haven't learned all the lab values. And so I tried to make it different. It'll be better next time. But pay attention to all that stuff, right? Do not give contrast. Now, yes, in a true setting, in a clinic setting, right? I tell you all the time, we got academia and we have clinical medicine, right? Academia, know when not to give contrast. In a true clinic setting, in an emergent setting, if you absolutely need that scan to figure out what is going on, I don't care about this. Because guess what I can do after the CT scan? I can admit them, pump them full of fluids, flush out the kidneys, monitor them, get them other meds to try to help them out if the kidneys do start to fail a little bit, and I can do things because they're in the hospital, because I need that, because if I don't get that, it could be a life or death situation, or like I need to have that diagnosis now. So in a true emergent clinic setting, sure, have this in the back of your mind, but you may skip over this. And you can do that when you're a licensed provider, because then all you gotta do is go, I knew the risks, but the benefit outweighed the risks, right? I saw the patients where they at, the benefit outweighed it, I was willing to accept that risk. You can't do that academically, because academically we gotta go by the letter of the law, what the books are, and what the PANCE is gonna test you on, right? So just know those things. Anaphylaxis we talked about already in the first block and a little bit in the second block. Know your reactions and don't give contrast if they have an allergic reaction to the contrast. All right. When do we do ultrasound on abdomen stuff? Trauma, especially if they're what? Unstable, right? We do that EFAST exam. We are not sending patients to CT if they're unstable, because what do they do there? Die. They die in CT. Don't do it. Any type of reproductive organ masses or pain, ultrasound is going to be your indication. That is testicles, ovary, uterus, anything that reproduces or has something to do with reproduction. With the exception of one thing, which we will talk about towards the end, it's the fallopian tubes. Ultrasound doesn't see those very good. We have a special study for that, and we'll talk about that later. But everything else that has to do with reproduction is ultrasound, okay? Vascular concerns, yeah, you can do it for the abdominal aorta if it's enlarged, because that's the screening thing, and we'll briefly talk about that. But if you're truly concerned about the aneurysm because you saw it on the ultrasound or from physical exam or a dissection, we talked about that already, that's going to be that CT with contrast to look at the aorta. But if you're just doing a screening, you'll do an ultrasound, and we'll, like I said, we'll talk about it. Right lower quadrant pain, appendix. Pay attention to what's after appendix. What two patient categories? Peds and what? What is gravid? Pregnant. Right? If you're evaluating for appendicitis, a CT is really good, right? But do I want to give that radiation to a kid or a pregnant woman if I have an ultrasound which might give me my diagnosis? No. It is user dependent. It is not 100%, right? But it's better to use the ultrasound on appendicitis patients for peds and pregnant women before jumping to a CT. Okay? And when we get there, we'll talk about that. We'll hit it again. Right upper quadrant pain, gallbladder is going to be ultrasound. You're trying to evaluate that gallbladder. That's going to be the study of choice. Even on CTs, you've seen some of them. Don't really see the gallbladder very much. Right? A lot of liver, but it doesn't really tell us much about the gallbladder because it's just this fluid-filled structure. The ultrasound can tell us a lot about inflammation, pain, that kind of thing. Free fluid, organ anatomy, blood flow, we'll talk about that. That's that Doppler for the torsion. OB assessment, right? Pregnant. Checking out baby. Checking out baby size, not checking baby's gender, right? That's not what we do the ultrasounds for. That's not what mom thinks. It's not what new dad thinks, right? We don't do the ultrasound to check baby's gender. We do check baby's growth and make sure they're growing appropriately. And sometimes we can find the gender and we get to tell them. But they're like, oh, I'm going in to find out baby's a boy or a girl. No, you're going in to make sure baby's growing healthy. That's what it's for. Because then they get really upset when they, like, I can't see it. Sorry, this time it doesn't work. You guys won't be doing it, but you'll be ordering it for your patients. Appendicitis we talked about. Cholecystitis, that's the gallbladder stuff. Hydronephrosis, we'll talk about that when we get to kidney stones. There are instances when we do ultrasound of the kidney to evaluate for the damage that a kidney stone is causing. Very specific instances we'll talk about in that slide. ERCP. Endoscopic retrograde cholangiopancreatography. All right? You one oral question on the test, you have to say that 5 times fast. If you don't, then sorry, you'll recycle. I'm kidding. Please don't write me up. Right? No. So ERCP is specifically for the biliary tree, right? The nice part about this is it uses endoscopy, and that's a fluoroscopy picture, right? So we talked about that C-arm before in surgery, how it can be used for procedures to see where we're going. That's what this is. It's a spot film from that. They were going in there on this particular patient They did some scans and they feel like there was a stone sitting in the biliary tree, so they're going in there to try to get it, right? So ERCPs are pretty cool. They're diagnostic and therapeutic because when they go in to evaluate, they go in, they'll squirt contrast in there, and they'll take some pictures. Sometimes the contrast they squirt in will pop whatever, either pop a stone out, or if part of the biliary tree is kind of adhesed on itself, that pressure can pop it back open. So that's where it's diagnostic and therapeutic. There are patients who have gone in for ERCPs and their problem was fixed. And a lot of times if it's like the biliary tree kind of adheses on itself, they never saw the problem to begin with because they injected the contrast to try to get a good picture of it and everything opened up and it looked good. And then magically their pain is gone and they feel better. Well, they fixed it through the ERCP. So this is going to be specifically to evaluate that biliary tree area, okay? Biliary tree and pancreatic ducts. There's your anatomy. Shocker. It does not always look pretty like that. All right? You can't just be like, oh, it's over here, so it's the large intestine. You'll have to trace this out, and we'll teach you and learn how to do that, right? Notice how we don't even have like a spleen over here. I promise you, spleens are still part of our anatomy. So these are anatomical pictures just to give you an idea, but understand the general areas of where the anatomy is. It will help you when trying to figure out what's going on with each of these images when you look at it. Here's what a CT looks like. This is where anatomy is important. You gotta know what you're looking at, right? You gotta know what you're looking at. So I have it all labeled here for you. This guy here in the center, right in front of the spine, all right? This guy here, what is that? That's the aorta. That's not the esophagus. How do I know it's not the esophagus? I'm down halfway through the abdomen. It doesn't go that far, right? So don't get that confused with esophagus. How do I know it's not trachea? Well, A, it's not in the lungs, right? But it's also not filled with air. So know your anatomy. This patient does have a right kidney. Why can't I see it? It's sitting underneath the liver, right? So the kidneys kind of sit like that. The liver will push that right one down a little bit. So you will get practice in the lab. We're going to do what's called a CT scavenger hunt. So I'm going to pull up actual CTs up here, and you guys are going to come up intermittently all the time, and I'm going to be like, hey, find me blank. And you're going to scroll through and like put the pointer on there and try to find the anatomy thing I want you to find. So you'll actually get some practice scrolling through a real CT and a couple of them to try to find different things as part of the lab. Here's your coronals and just your coronals right now, right? So now we got our spleen, we got our liver, we got kidney. Can't see that one there. We got large intestine, we got small intestine, right? What's that guy right there? Let's circle that again. That guy. That's the gallbladder. Notice how it's just kind of like a different, it's more radiolucent. Why is that? Well, I got a bunch of contrast going on here. The gallbladder's got nothing inside. There's no tissue. It's just this hollow organ filled with liquid or bile in this case, right? So it's not going to obtain any of that contrast because I don't have vasculature like I do going through the liver here. I don't have any of that going into the gallbladder because it's a hollow organ, right? So all of these are your vasculature, your mesenteric vasculature coming out and feeding the intestines. So you can scroll through and do all that. Okay. How do we evaluate the abdomen? We're going to focus on 4 main areas. The overall gas pattern. What is it supposed to look like? Because again, you can't find abnormal if you don't know normal, right? So what is normal? What should it look like? Should there be air in the abdomen? That was a real question. Yes. Where should it be confined to? Yeah, the GI tract, right? Stomach and intestines. It shouldn't be anywhere else. It should be within the stomach and the intestines. What else should we have in the intestines? Stool. We'll use the official word. Stool, right? We should have stool sitting in there too. So we're going to see both. And there's a certain pattern that kind of we expect to see in different areas. Do you expect more air in the large intestine or more air in the small intestine? The large, right? The large intestine. Because the small intestine is what's digesting all of that food from a lot of that bacteria. The gas gets passed, it gets moved to the large intestine. So you should see more air in that. You can have some air in the small intestine, but more air usually in the large intestine. We're going to look at some of that stuff. Soft tissue masses or organomegaly. right? We know where the liver should be. You guys did it for Clean Skills too. You have a general idea of how large the liver should be, not by centimeters. Like, yeah, that's important to know. But I mean, just by general, when you're doing the hook method and you're feeling for the bottom of the liver, you know it projects slightly past the 12th rib, or it can. You also know that, how many of you felt the spleen? How many that got abdomen felt the spleen? Come on, be honest. Good, you're being honest. None of you felt the spleen, right? Because when the spleen's normal, you shouldn't feel the spleen on that physical exam. So it shouldn't protrude past the 12th rib. So when we get to these x-rays, if we see a spleen that is coming down inferior to the 12th rib, guess what we have? We have splenomegaly. And you can call that because we know that the spleen's not supposed to be past the 12th rib, right? So we can see this stuff on x-ray. That's what we're going to teach you to look at. Abnormal calcifications, look at those as they come through. And this is what it talks about. Normally, air is present in the stomach and colon, especially the rectosigmoid. Right, that's the end part right before we get to our rectum, before we pass gas or use the restroom. You can have a small amount in the small bowel, but it's not tons. And usually you don't ever order just an abdomen x-ray, right? You end up getting what's called an acute abdominal series. Okay, that's what the order is called, an acute abdominal series. It comes with a supine abdomen, so I'm lying down, an upright abdomen, standing up, and then an upright chest. So a PA chest. Why would I get a PA chest? What am I looking for in a chest x-ray? Air where? Under the diaphragm, right? I want two views of that diaphragm, depending on how well they did that upright abdomen. Now, on the upright abdomen, I might get that air under the diaphragm too. But if I combine it with that chest x-ray, I can guarantee you I'm going to be able to see that and be able to make that evaluation and look at it, right? So yeah, supine abdomen is going to show you your natural bowel gas pattern. The upright is going to show you air fluid levels if there are any, because again, gravity is going to drop the fluid down, let the air rise up, so you get that. And we're going to look at all those x-rays. But those are typically the three pictures you're going to get. You may get 3 of them on the exam. Just like the first exam, I will give you the number of pictures you need to answer the question, right? So if you're like, hey, I would really like to have a lateral, yeah, so would I, but you don't need it for this question, so continue on, right? But cause I try to limit the pictures to not kill the bandwidth, right? Most of you didn't have many image problems in the first one. All right, so we're going to cover normal studies, calcification, acromegaly, all the stuff we talked about. Let's start with our normal patterns. This is a supine patient and a prone patient. You are almost never going to order a prone x-ray. I showed this to you to show on the same patient, positioning changes your bowel gas. Because the intestines are positioned differently, right? And it's going to change your bowel gas in that aspect. So we expect to see it in the stomach, a little bit in the small intestine, but mostly in the large intestine. So here's rectosigmoid gas, here's some ascending colon gas, here's some transverse colon gas. My small intestine is all in here, right? I don't see a whole lot. A little bit maybe, like right there, right? And then that's probably part of the ascending colon coming up to the hepatic flexure. So a little bit of gas right there, but not a lot, right? When I flip prone, well, what happens? My intestines are different. So when I flip prone, that air gas is going to rise back further. So that's why it looks a little bit different. But you can still really see a lot of the rectosigmoid gas, a lot of the descending colon gas. That's what all of this is, okay? All the descending colon. You get a little bit of small bowel gas still kind of in here, but that's all large bowel gas. Really for normal, I want you guys to focus on the supine. I'm not going to give you a prone x-ray. This is just to show the fact that positioning matters when it comes to bowel gas pattern, okay? So what you're really looking for is, look at my gas. Would you be safe to say that when I look at the gas pattern that I can probably go, yeah, it's contained within the intestines there, right? I can kind of make out the shape of an intestine, the walls of an intestine, right? I don't have like weird gas kind of floating up here where it's not supposed to be, or up in here. I can draw out intestine, or probably intestine there. I can make a nice little, right? I can make that shape. So it's not really extraluminal air. It's within the intestines where it's supposed to be. Then you look for calcifications. We don't have anything on this one in soft tissue masses. Take a look here. Can you follow the liver down and see how it comes down here and then it kind of comes up? Does everybody see that? We'll have other pictures with liver, but I just want to show you. Here's rib 12. And the liver comes down slightly past the 12th rib and comes up. This is that soft tissue line that you're looking at. That's normal. The liver is supposed to be slightly larger or slightly past the 12th rib. So more normal bowel gas patterns, right? All bowel is slightly distended because of the air. It's not dilated. We will look at dilated bowel later. We almost always expect some type of air bubble, and there's not really a good one here. It's like kind of like right here. Some type of air bubble up in this region. That's my gastric bubble. It is not abnormal to have air in the stomach. All right. Small bowel, sometimes we have some loops. And then again, large bowel, there's some descending colon. Okay. You can see here how I have the ascending colon. And then I have like, it's like gas and like this mottled appearance. You guys see the mottled appearance? All right. That's stool. So that's stool mixed with gas. When it has kind of like this weird mottled, kind of looks like a sponge is sitting in there, but there's some air sitting in there. It's got that spongy type texture looks to it. That's stool as opposed to bowel gas. Does anybody notice any foreign bodies? See the surgical clips? Some surgical clips there. And then if I trace my liver down, whoa. Probably hepatomegaly, right? We haven't seen a whole lot when the liver has gone down into the iliac crest. We haven't seen a whole lot of liver yet at all. We'll see some other ones. But again, tracing that soft tissue line of that liver that comes down into the iliac crest. How old do you think this patient is? Pretty old. What's the sign on that? Yeah, look at my calcifications too, like around the ribs. Like that cartilage is starting to calcify a little bit. So another thing with the large bowel versus the small bowel, right? If I stand you upright, how often do you think you would expect to see air fluid levels in the large bowel? Very rare, because what's the large bowel's job? Except take all that moisture out, absorb all that fluid. So by the time I get down to the descending colon, all that fluid's being absorbed. There shouldn't be a whole lot of fluid in the large bowel. And that's going to be a sign later on. When we start to see some abnormalities and you're trying to figure out, is it small bowel or is it large bowel? If you see air fluid levels, it's probably more likely than not small bowel. There's a lot of fluid in the small bowel. There's not very much fluid in the large bowel, right? So, how do we differentiate? Large bowel is typically peripherally located, right? Like we talked about in that picture. But it can be pushed and moved and go all over the place. So typically it's that. You can use the haustra. Now when we look at it more, we're going to look at it with contrast, a lot easier to see. The haustra versus the valvular coniventes, right? The haustra are not going to be completely circle all the way around. You'll see what I'm talking about on X-ray, right? You'll see a line all the way through. That's your valvular coniventes. And then we see it kind of partially and stop. Those little folds are your large bowel. Those are going to be your haustra, okay? And so we'll just kind of go into the pictures and take a look at that. So you can see how, let's go over here on this side here. You can see my lines are coming across, right? And they're kind of like, I don't have a lot of lines coming across. This is mostly large bowel. It kind of comes over here and here. Plus, I can make my shape fairly well of what the large bowel is supposed to look like. So I have ascending colon, transverse colon, and then it's supposed to be descending. Can't see a whole lot of it because this air hasn't made its way all the way down yet. But eventually this air is going to make its way down into the descending colon. This here is a barium enema. This is where we put contrast up in here, rectosigmoid, descending, splenic flexure. Look at this shape. Transverse, hepatic flexure, down ascending. So it's not always this perfect little kind of shaped guy that we see in the anatomy, right? How do I know this is large bowel and not small bowel? Well, a couple of reasons. One, it's a barium enema. I ordered it and we're doing it. So I know that because that's where I put the contrast. But secondly, see all these little white pouches here? Diverticula. That's a large bowel issue. Again, I can have my general shape, hepatic flexure, transverse colon, sure it's a little funky, but splenic flexure, descending colon, right? Whereas the small bowel is like, it's all sitting in here, right? And we'll see some pictures of what it looks like when we highlight the small bowel, and then the difference will stand out just a little bit more, But right now, we're focused on kind of the large bowel stuff and looking at it. More normal studies, right? Just like in past blocks, I give you lots of different types of normals so you can see what they look like, so you can understand what normal is in order to figure out what abnormal is later. Again, I have a gastric bubble. That is normal. Small intestine, few loops here. Is this an upright or a supine abdomen? How do we know it's upright? You want to get fancy and be smart and say air fluid levels? Fine. I prefer just to look down here where it says upright. So, it's just me, but simple guy. But you are correct. Air fluid levels is another sign, right? If I have that nice flat air fluid line, then yes, it's upright because I have gravity working with me, bringing the air up and bringing the fluid down. Also, almost all of your abdomen x-rays should say upright. If it's not upright, you can assume it's supine. That's just the standard when they label these things. They might say supine, but they should definitely say upright if they're upright images. Which means, since I have an upright image, which intestine do you think this is? Small bowel. I have a lot of little air fluid levels, but boy, it's right in where that ascending colon should be. It sure is, but I don't get air fluid levels in my large intestine. Okay? Minimal to no air fluid levels. Okay? So you're going to have that. So it's upright, I got air fluid levels. That's small intestine. We're likely got large intestine right here. I don't really see air fluid levels there. It's kind of pretty well circular in that aspect. But just to kind of give you an idea. What's this pointing to? Yeah, it's a diaphragm, right? I'm trying to look to see if there's any free air in there. It's not the greatest picture in the world for that, which is why it's not on the free air slide right now. But just going to show you, it's another area you need to look. It's another area you need to look, because if there's free air into the diaphragm, what are the odds I'm going to see it here? Probably not too great, because I already have a giant air gastric bubble that's supposed to be there. So a lot of times, when you're looking for free air, you're always looking on the right side from where the liver's at, because it'll provide that contrast. Here's a chart for my chart people. Right? Different types of learning, different types of methods. This kind of lets you know, based off, again, prone abdomen, great. You're never going to order a prone abdomen x-ray. Gas and the rectal sigmoid, that's where it's supposed to be. You can see that on supine. But it does give you ideas between the supine abdomen, the upright abdomen, and the upright chest, some of the main things you're going to be looking for, right? Your overall bowel gas pattern, calcifications and masses. Then we do the upright to look for the air fluid levels in the bowel and look for that free air in the diaphragm. And yes, you can see pneumonia and pleural effusion in the chest x-ray, which is important, but we're also using that for free air when we're talking about abdomen stuff. This is where that, again, falls into the play of, if I have an abdomen complaint, I'm going to do the system above and below. If I have a chest complaint, I'm going to do the system above and below, because what if the actual problem is in a different system than where I'm feeling my symptoms, right? And so that's why we kind of order it this way, just to make sure. You think a perforation of the bowel with free air to the diaphragm can cause chest pain? Absolutely, right? It can cause chest pain. It can cause palpitations from the pain. It can cause all kinds, cause indigestion, cause all kinds of stuff, right? But I'm coming in for chest pain, but the problem is actually bowel. You don't get the acute abdomen series, you're going to miss that. And now this is the chart, but in words. Okay? So I'm not going to read this again. It's just on the chart for those who like words. All right. How are we doing? Okay? Let's go through a couple of abnormal calcifications, then we'll take a break. Phleboliths, we've talked about these, right? They are calcifications in the veins, right? They're benign. They're not going to cause any problems. They rarely cause any pain. We often see them in older women. I don't know why. It's women more than men. You ask how they love that in senior semester? I don't. It's just more common in women. They're just calcifications in the veins, particularly in the pelvic region, in that aspect. Okay? So nice little round areas, just kind of sitting and free floating, right? And the reason we know they're phleboliths and not stones is there ain't any kidney stone or urinal stone that size that's going to make its way into the bladder. That is big, right? If you were to actually measure that in like the little CT thing, it's going to be larger than the stone. Do you know what the stone size is that can pass through a ureter? Yeah, less than 5 millimeters, right? 5 is kind of the question mark. That's kind of the cutoff. These things, if you measure them, are bigger than 5 millimeters. So, and on top of that, they should be sitting down here if they were stones in the bladder, right? Yeah, no. Depends, is she upright or not? Right, because the posterior bladder can be sitting right here, but you're not gonna see stones in the bladder typically, on an x-ray. When they're that big, they're gonna be the fleetless. Another abnormal calcification that is benign a lot of the times is gonna be rib cartilage. Right? And the way you know it's rib cartilage is because it goes in the shape with the ribs. Right? And it's right up here into the ribs, and it has that shape right there. It's got that mottled appearance, it's gonna have the shape of the ribs. I'm not worried about cartilage calcifications in the ribs, but these are something that you could end up seeing. Okay? Now there are 4 types of abnormal calcifications that are concerning, that can cause pain, discomfort, and things we need to take care of and treat or evaluate further. One of them is the rim-like calcifications. We typically will see this in the gallbladder. This is called a porcelain gallbladder. The entire gallbladder is calcified on the outside. That's going to cause some pain and some discomfort. Okay? You can also have it in the kidneys. You can have renal cysts, splenic cysts. We've already kind of seen some of the aortas and some of the vasculature a little bit, how that kind of calcifies depending on where that's at. If it's an aortic aneurysm, that's going to be considered a rim-like one. Really, the one you're going to see the most likely is going to be this porcelain gallbladder. I've never seen a urinary bladder fully calcified, but it doesn't mean it can't happen. But the gallbladder one, that can be quite painful for them. Okay. I've had this confused before. So, white arrow is the femur. The white arrow is not the artery. The black arrows are the femoral artery, and the red arrows. That artery wall is starting to calcify, right? This can still happen to ureters and fallopian tubes. Any tubular structure that starts to calcify, right? A linear or tract-like structure. This is an amputation. This is not the calcified artery wall, right? You can see the surgical clips right here. That's the femur. So that is an abnormal calcification, right? It is not, the vessel's still working, but it's not going to be as pliable, right? That artery is not going to be do as well as it can be pushing the blood around. Let me finish these last two, and then we'll get you on break. Glandular, right? So renal stones, gallstones, bladder stones. You don't often see gallstones on x-ray. Not often, you can. And if you do though, this is what it looks like. It looks like somebody took a bunch of pebbles from outside and just put it into the gallbladder. Okay? You see them sometimes better on CT or ultrasound. We'll pull out the stones quite well. That's why we use the ultrasound for the gallbladder. Right? If you ever see something, an abnormality on a gallbladder on CT, the odds are it either started like this and they were trying to evaluate it further, or they were ordering a CT for something else and they incidentally found gallstones. Right? One time I did a CT to where there was one giant stone that took up the entire gallbladder. But guess what? The patient wasn't having any symptoms. So you know what they did for him? Absolutely nothing for that. No reason to do a surgery if you're not having problems. Now, the second that patient started to have pain or whatever, they're going to go in, do a cholecystectomy, and take it out. Right? Not going to do a surgery if you don't have to. But you get to see all kinds of stuff when it comes to the gallstones on the CT or the ultrasound. And then lastly, the stuff that worries us. The amorphous or popcorn or cloud-like kind of calcifications, right? Most likely going to be in your uterus, your lymph nodes, body of the pancreas. This is bad news, guys. This is a chronic calcific pancreatitis, which is likely going to be leading to a pancreatic cancer because of how bad the pancreas is inflamed and angry, right? Pancreas should not be visible on x-ray ever in any situation. It's hard to find on CT if you don't give contrast. So if you see something in the shape of a pancreas on an x-ray with these calcifications, your next step is CT, and then probably some labs, because you got to figure out if they got pancreatic cancer or not, because it's probably likely. Don't memorize the chart. This is going to be more for your phase 2, more for your anatomy stuff to help understand where things are at. I am not going to be like, oh, what is the amorphous calcification area? And then have choices like tail of pancreas, iliac artery. I'm not here for that. That has nothing to do with radiology, right? Take a break, come back at 3 after, and we'll jump into the second part.
That was loud.
Big ribs.
I'm done studying by.
Just like trying so hard. I heard it.
Like the littlest thing you guys.
Yeah, so give me that one.
I thought you were gonna walk out.
15 minutes. First farm test was
Something about a food, about
study 20 minutes, do this one thing, and then it grows and grows. I sit back down like, I sit back down 20 minutes later, study this is the thing that I make
I think I heard you first and then Kyle. I always assume Kyle likes it.
farm what's helping me
No,
is,
were you laughing? So he was already and then he started laughing. He went like, started laughing.
You can tell it's really bad when I turn before.
You're gonna step back.
make stuff up. I'm like,
Once I turn it,
services do it different, yeah, the services
When I
are
heard
very
him
different,
laugh, I
so.
was like, oh no, what are you gonna say?
I wasn't even looking at him. I was like, I see him go down, his face was red. Oh, God.
Somebody needs to take their phone away. I feel like just anything that's happening is so quick.
Yeah, so there's gonna
I thought you were gonna say
Oh, you're serious? As soon as I saw you laughing, I heard you laughing, I quickly put my phone on do not disturb. He said he felt this.
Save yourself.
It was you. You did not say anything. I heard it. So it was just a jank.
Well, I guess so.
And I heard you laughing, I was like, oh, God.
That was very impressive though. Oh, thank you.
That wasn't as bad as he said.
I don't even realize I said that.
Not me.
I didn't realize I said
Everybody in there had
It's fun to try.
I can never find it.
Yeah, I didn't even realize I did that.
Oh man, recognize this person. Yeah, I mean, it's pushed out in the
It looks like it has
What is barbed wire? This is barbed wire to me. Was that posted on like the German or the Europe.com?
Yeah, but he had to be doing
I
it.
heard it, and I'm like, ah, and then he said,
I was like,
oh, damn it. And then I started cracking up even more, and I heard him laughing, I was like, I kind of.
How do you like this like
You don't see that that often.
I
Every time he's And I know if I hear that, I'm gonna look over and see with your head down, because it's every time it's this.
Kyle, I feel like you're sleeping a lot.
You go.
Did you eat?
So you could.
Right in the middle.
Push my chair back and turn towards the voice. So I don't see them anymore.
Always like, oh, is she gonna walk out?
It's like the greatest battle ever. You stay to walk out. When you said the video, me.
Which is like such a little thing, though.
I'm struggling, dog. I'm struggling.
I don't pipe up.
Pipe up. Ah! Need me to get louder? Okay.
Yeah.
Oh, dog.
I mean, like, tight.
Yeah.
Minus talking to Bill, you have like, yeah. Cover some good ground that's vibing.
Yeah.
I'm like, yeah, you gotta be at 2 quarters.
Oh, ow. Legs. Legs time, too.
How'd you have that?
Well, these are the regular ones.
Feel like
Shine them up just a little bit today.
oh,
A little oil in there.
I have like this balm stuff. I'll use a brush and I'll put it in the usually I'll take that balm stuff, add it on, wipe it down, like brings back to life.
I used to be really good at shining on shoes.
Oh man.
That's me. That's me. I used to be really good at it.
I really thought that was going to be such a big deal. Going on, like keeping it shine. Oh wait, my normal boots going to do that.
Yeah.
I mean, like my age is last almost 8 years.
Yeah, you should not.
A year ago, almost 2 years ago.
Next week graduation. I'm gonna get a renewed top, or like I'm gonna have to get something done. Well, when I've gotten conditioned in it, it was thing is, like, it fits me and everything, but it's so tight around the arms that they couldn't let out the arms. It's like, no, that's like the main part of the thing that I can't alter. Like, you can't. I bet I can find somebody who can alter the arms or whatever, because like just right here just pinches, right here, and then just.
I've watched it on that old uniforms, even the way they're cut, the way they fit, it's better. Box, it's not as nice. Even my grandparents, like, they were taking it wasn't just for that, and they would fit that. Not so massively. Not as sharp. Because your box doesn't matter, like, it doesn't matter what your bottom side is.
What is hold?
I need it.
Or just take it.
He's taking a break. Take over. So, anyways, how does this radiograph compute with micro? Pulls up a radiograph. Okay, what do we got here?
What kind of fluke is this?
Joke's on you, it's histoplasmosis. You should have seen it by the way it is.
That was a lot of class.
You can tell that it's coccyioides by the way it is. Neat.
I remember the first time she bought herself. It was like, it's pretty.
Yeah, right, remember that? Pretty simple. Pretty simple.
I remember just feeling like I wanted to rip out my hair.
Right? I keep telling myself I made it through micro, I can make it.
That.
Bears well, which bear? Polar bear. Fake man. If there's any bear I don't want after me, it's a polar bear. You're gonna die. There's no ifs, ands, or buts. Just dead.
Hope you got a gun.
Hope you got a big one. Have you seen like a grandma like comparison? Like a like size comparisons?
They stand up for
Yeah, stand up there. They're like that's like a, they're great ones. Body's tightened up. My African massages in my house late nights. Good prices.
Korea.
Yeah, oh, I got
Oh, you want a massage?
plenty. Did a special for
You
you.
know, like, I don't know what this word is. Like, good. I'll be there. Let me know what
That was one thing about the base that on had you can pay get a massage. Nice.
on the refresh between last night.
Nice.
This lady, she was my not hand wrapped, but was stabilized by holding some sort of sheet walking. Yeah.
Oh yeah.
I had 2 massages on the mat. It was great.
I like going for those. We go for quite a few pedicures. I'll go get a pedicure, man. I'll have a little Asian man rub my feet. Like
I
it's.
just like when I get scorched.
Oh yeah. I always have to tell them like, hey, whatever your hardest is, go a little bit harder. You know the point of your elbow? Just get a knife. Just get in there. Yeah. Well, I actually like those things. Break your break. Actually, I
Oh yeah, that's right. Would you like a pack?
Yes.
During this block?
soy. Go your testicles. Here goes my testicles.
I got 2 kids. They could take them. Put some fake ones in. Make me know. Not, you know, like you do for a dog. Keep it proud of itself. You know.
Alright, take a seat just now, give you the next minutes, working out some admin stuff. Yeah, it's Friday. Any Saints fans? No other Saints? No? Good. More sports stuff. Sports ball. I can do like sci-fi stuff too. Star Wars, Marvel, no? Yeah. Alright, I'm a nerd. I'm not excited. I got kids. I can talk like K-pop demon hunters too. If you guys are into that. There you go. Put Golden up on the podium on the next break. Yeah. All right, let's get back into it. Trying to connect with you guys. Your generation. Since I'm older than Aaron Rodgers. Okay. Organomegaly, right? So now we're going to look at the organs that are large. Nice part about this section, there's only a couple that we really kind of care about, and that we can really see on an X-ray. But what is the issue with organomegaly? It can be hard to distinguish them on plain film radiograph. You have to use your eyes and kind of look at the densities, right? Look at, they don't stand out that well. But if you look at it closely and you understand kind of where they're supposed to be, what the shape is supposed to be, you can kind of make it out, right? Game of shadows. Remember, game of shadows. There are two ways that we can do this. We can do this either by seeing the actual organ, like I showed you on the liver, right? We can do it by that. Or sometimes in our, we'll say, fluffier population, right? Those organs aren't that visible. Why? Because I have a lot of visceral subcutaneous tissue, okay? Which means by the time it gets to the organs, time it gets there, I can't see it because the radiation has been absorbed by that subcutaneous tissue, and so now it's just all one color of gray. Well, we can use indirect evidence that there is a mass. We just got done talking about where the large bowel kind of should be, right? This general shape of where it should be. If all of a sudden I don't have any large bowel, any air, say up in the left upper quadrant, and it's all kind of pushed away and down into the center of the abdomen, then I can only assume that something is pushing it. There's a mass or something there. Do I know it's an enlarged spleen? Not entirely, probably, but I don't know that for sure. But there's something pushing that bowel away, and that's my indirect evidence, okay? So, for example, really hard for me to make out the liver on this one, right? But we know that the liver is going to displace any bowel gas in the extreme right upper quadrant because that's where the liver sits. We're not going to have a whole lot there. It's normal for it to push it down just a little bit. But I should have some bowel gas kind of coming up here. So if I don't, then I can assume I might have an enlarged liver. I can't make the liver out. But what the black arrows are showing you is where the edge of this liver actually is. More like kind of like here and not this way. Because it's pushing all the bowel gas down and around, all right? So you will get better practice at that the more you look at these x-rays in clinical and things like that. If I give you an organomegaly one, I'm probably gonna try to find you one that looks a little bit more like this, okay? This is more of a direct visualization. Now, we will talk about the Rydell lobe and the normal variant thing here in just a second, but look at my liver coming all the way down, right? That's all the way down into that iliac area. The liver coming past the 12th rib, normal. Even coming down here, I'm probably not too concerned. If I'm infringing on the iliac crest, that is hepatomegaly, right? What's this? Anybody know what that is? That's the kidney. Look at the shape. It's bean-shaped. Right? It is super rare to see the kidneys on x-ray. This patient is really thin, so we can see the kidneys quite well. But it is hard to see the kidneys because what is it? There's a lot of fat, there's a lot of bowel, there's a lot of things kind of in the way of the kidneys. Now, this Rydell lobe, right, this normal variant of Rydell lobe, I just need you to be aware of that. Because what's going to happen, if you see a liver that's enlarged on an x-ray, are you done evaluating this patient? You're going to get more imaging. You might get a CT. You might get an ultrasound, depending on what's going on. Either way, what's going to happen is they're going to look at it from a radiological standpoint, and they're going to be like, oh, after the imaging, that's a Rydell lobe. Now you know you don't got to do anything for that patient. A Rydell lobe, yes, it's technically an enlarged liver, but it's not enlarged due to like a disease. It's not like a fatty liver. It's not enlarged due to high cholesterol. It's not enlarged due to cirrhosis. It's just a normal variant. So no further treatment or evaluation needs to happen with that patient because it's just enlarged because it has that extra lobe. Does that make sense of why that's in there? Right? Just so you understand, when you see Rydell lobe, that's fine. The patient's healthy. You don't got to worry about anything. Any other reason for hepatomegaly that's not Rydell lobe, you got to figure out why. Right? And you'll learn that in the other ologies. You got to figure out why so you can fix the why so that way their liver doesn't completely tank. A lot of times it's going to be cirrhosis, alcohol, fatty liver disease, could be cancer, could be all kinds of reasons. Your job is to figure out why once you find it. Spleen. We have two things going on here. First, here's my 12th rib. I can directly visualize my spleen coming down around there. I am past the 12th rib, that is splenomegaly. So that's the first thing. I have my direct visualization. I also have indirect visualization with my descending colon into my transverse. It is being pushed this way. The white arrows are showing you the edge of the spleen and the edge of the bowel to show how the bowel gas is being displaced. It should be sitting up here, right? Because the spleen should be well under the ribs. My bowel gas should come all the way up here. In retrospect, it's not abnormal. Here's rib 12. Liver is coming down. Here's my bowel. Not abnormal to have an absence of bowel gas in the right upper quadrant because the liver is there. But I should have it in the left upper quadrant because the spleen is not supposed to be there. So that's my splenomegaly there. It should not project past the 12th posterior rib. Okay? If it does, you are safe to call it splenomegaly. And now if I have splenomegaly, the next question is, why? Right? I don't know if I have that in here, not yet. Most commonly, probably something like mono, right? So you gotta give really strict precautions, no direct impact, no contact sports, all that kind of stuff to make it better. Because the concern we have here now is if my spleen is projected past the 12th rib, what's the problem with that? It's not protected. Spleens can rupture fairly easily, especially if they're enlarged or they're inflamed. So now I don't have the ribs to protect it. That's why we want the spleen to be under the ribs. We want it fully protected. So if you have an enlarged spleen, whether you know it's mono or not, until you figure out why, you should give the precautions of, hey, no contact sports, none of that kind of stuff, no direct impact to the abdomen, don't do any activities that cause that. If you plan on going snowboarding this weekend, I would recommend you don't, whatever the case is going to be. Start asking those questions of like, what are your recent plans or what are your hobbies, things like that, so you need to counsel them appropriately until you can figure out why and see if we can shrink the spleen back down. Kidneys, rare to see on x-ray. But, oh boy. Now how do I know that's a kidney and not a spleen? I don't. I got the CT, and here's the kidney, and here's the giant cyst that is sitting on that kidney. So the kidney is not actually enlarged. It just has a giant renal cyst on the outside of it. But can I tell that from just x-ray? No. I see some kind of mass. I see some kind of enlarged organ. I see this giant radio-opaque thing that's not supposed to be there. All of my bowel gas is being pushed out of that entire side of the abdomen. That's my indirect evidence. I don't know why. What's my next step? I'm ordering a CT. I find a kidney that's being compressed from a giant cyst. Because soft tissue and fluid look the same on x-ray. So we can't tell the difference. But we know there's an abnormality. And we have to evaluate it further. Bladder, same concept. Which area of the bowel has the most air? Rectosigmoid. Normally sits right in here. Where is it? I don't have any. On top of that, look at my radio-opaque line. That is huge. What is going on there? So the urinary bladder is insane. It can expand to very large sizes. Size of a cantaloupe. A small cantaloupe, the urinary bladder can expunge. Now, most of us aren't going to get there because we're going to go to the bathroom. It's going to force itself out, right? But if there is issues, other issues, urethral stricture, something going on with the sphincter, something that's not allowing the urine to leave the bladder, this can happen. Or, more concerning, what's more likely that's going on here? Not a stone, cancer. Likely bladder cancer, more likely. I can't tell with just the x-ray, but, all right, I'm gonna get a CT to try to find out more, figure out what that mass is. Stones are possible, right, if it is blocking the urethral area and causing it to fill up. BPH is another one, right, causing that urethral stricture to where the patient can't use the bathroom as well as they want to, so it just builds up, builds up, builds up, they're coming in for pain, and here you go, right? But cancer should also be on your differential. But that's your bladder, and again, what you're using is, you can't visualize the bladder itself, but you're using that indirect visualization to go, hey, my bowel gas isn't going anywhere past like the superior root of my pelvis. That's weird. I should have bowel gas lower than that. Probably an enlarged bladder. Enlarged uterus. Very similar location to the bladder, but slightly superior to it. So what do I have here that's different than the other one? I have my rectosigmoid gas. But now where's all my bowel gas that's sitting in the lower abdomen? It's not there. And look, I have this nice rounded shape. I have my indirect visual evidence that I have some type of mass or enlarged organ in this case pushing my bowel gas out of the way. Right? In this case, it's the uterus. Can you tell that just by this picture? No. Can you make an educated guess? Sure. If it's a female and I see the rectosigmoid gas and I know that it's not the bladder because it's not hiding that gas there, and based off of where it's at, I can make a pretty good guess. So if I suspect it's the uterus, what am I ordering? Ultrasound. It's one of the few abdominal masses or enlarged organs in the abdomen that if we want further evaluation of, we're going to order an ultrasound because it is a reproductive organ. So we're still going to order that. Might they need a CT on this eventually? It's possible, but we're going to do the ultrasound first to see if we can figure out what's going on. Okay. Know your 4 patterns of abnormal calcifications, right? These ones are what? Leaflets. Look at the location, a little bit radiolucent center. Okay. Which organ is enlarged? The liver. Good. What study is going to help you differentiate between uterine and urinary enlargement? Ultrasound, because I got the uterus in there, right? So that will help me figure it out if you're not sure. What are these guys? Calcified rib cartilage, not calcified ribs, right? Ribs are calcified. They're bones by nature. They should be calcified. The cartilage. Good. All right, let's get into some free air. Questions so far? Do you have anything after me? No? I didn't mean to sound so evil. I apologize. All right, nothing after me. Great. So my goal is I'm going to drive through as much as I can, right? I'm going to tell you guys right now. So on Monday, we now have that 10 o'clock session and that 1500 session, right? Yeah, 15 to 1700, my favorite. So what I'm going to do is we're going to push what we can here, okay? And then we're going to see where we end at that 12 o'clock session on Monday. I've already talked to Major Villalobos, and if we're close, like 30 minutes or less close, we may push and finish rads, still give you your lunch, push him to like 1:15, 1:30, depending on where I'm at, to give you your full lunch. So that way when he's done, you guys are done, okay? If we're any more than 30 minutes left to go, then I'm not gonna do that, and we'll finish with the 1500, but that's my goal. Because I know you guys don't wanna take till 1700, right?
Right.
I would love to, but I know you guys don't want to. Okay. All right, so let's look at free air, right? Let's see what we can do. So there's 4 common areas we're going to look, right? Intraperitoneal, retroperitoneal, pneumatosis, pneumobilia. We're going to look at all these things, all right? 3 major radiological signs of free air. 3 major signs. Can you see air beneath the diaphragm? Air should never be beneath the diaphragm unless it's the gastric bubble. But even then, if it's on that side, sometimes you can see diaphragm, air, and gastric bubble because you can clearly see the stomach wall. So air should never be beneath the diaphragm. It's not supposed to be there. So the liver is supposed to be, right? Visualization of both sides of the bowel wall. So far, we've been looking at x-rays. We've seen air in the bowel, and we've been able to see the kind of work like within the bowel, right? You can't really make out the wall, but you can tell like where the air ends, say, hey, that's bowel wall. But you wouldn't be able to tell me that bowel wall starts and then where does it end, right? So it's all soft tissue. If you end up being able to pull out the bowel wall, that means there's air outside of that bowel that's laying up against it, kind of like the shadow game we play with some of the chest stuff, right? So if you can see both sides of the bowel wall, then that's a problem. That means that there's air, free air in the abdomen. Also, visualization of the falciform ligament. Where's the falciform ligament? What organ? Liver. Have we seen that on any of these images? No. But much like when we talked about the subcutaneous emphysema, right? When air got into that pectoral muscle, we saw all those striations of that pectoral muscle because that air was sitting in there. If there's air sitting around the liver, same thing, you might be able to see the falciform ligament. That's not normal. That tells you there's some air sitting in that liver somewhere that's allowing you to see it, kind of like when we do that pectoral muscle. So, how are we going to see these things? So air beneath the diaphragm. you need to be in an upright or a left lateral decubitus. Left lateral decubitus. Why not right lateral? Think about that for a second. So when I talked about the lateral decubitus, if I tell you it's a left lateral decubitus, what side is lying flat on the table? Left lateral decubitus. The left side is on the table. It's named for side down, which means my right side is up. Okay. So I'm looking for air, right? So that makes sense. Why can't I do it the other way? If I lay on my right side, say it again. Stomach and the gastric bubble, right? When I lay on my side, I'm trying to get that air to rise to the peritoneum area so I can see it. I got all liver here. It's going to hide just like it should. It's supposed to be there just like it should if it's there. If I flip on the other side, that stomach's going to shift, that air from the gastric bubble is going to shift, and that free air in the abdomen could be hiding behind that gastric bubble. So that's why in a pleural effusion, you can do a left or right lateral depending on what you're measuring. In looking for air beneath the diaphragm, you can only do a left lateral decubitus. Does that make sense? All right. Both sides of the bowel wall, you're going to have a large amount of free air, but you'll see it in any position. Okay, it's called a Wriggler sign. I'm not going to hit you on that, but it's, you sound really smart and cool. Just be careful if you do that, like when you go to phase 2, because if you sound smart and cool, they're going to ask you harder questions. Right? Big picture. Be smart, but not too smart. Okay. And the visualization of the fast formula I got there in the chart, right? Large amount of free air. That one you're going to want the patient to be supine, because if they're upright, all that air is going to move up. It's not going to be laying across the liver or the falciform ligament, right? So you want them to be supine to be able to see that. This, again, 4 common locations. All right. Intraperitoneal. Well, let's look at it. So this one, you can actually see the free air under the diaphragm on both sides. This thin, white, radio-opaque line is my diaphragm. That's my liver. That's all air. That should not be there. Same thing. Thin, white, radio-opaque line is the diaphragm. This here is actually the stomach and the gastric bubble. So in this case, you can actually see air on both sides, but I have air beneath the diaphragm. What does air beneath the diaphragm tell me? I got a perforation. Where? I have no idea, right? Yes, a peptic ulcer is the most common, but you really have no idea. You just know it's perforation. For example, if like same thing with the thorax, right? If I have a pneumothorax and I have no trauma, it was likely a bleb or a volar and it kind of burst, causing air to do that. Where did it come from? I don't know if it was here, or if it was here, or if it was here, because air rises, right? So I don't know where the perforation is. I just know it came from somewhere. Perforated peptic ulcer is the most common. Most common cause for the peptic ulcers is going to be H. pylori. You're going to learn all that in GI. That's 100% accurate. That's the first thing I would be thinking of if I saw this on X-ray, but just know that it doesn't necessarily mean that. You could have a diverticuli that perforated, right, and it's still going to cause the same type of thing of free air under the diaphragm. Yeah, air is best demonstrated on CT. Everything's best demonstrated on CT. But an X-ray is enough to be able to diagnose this if it's bad. Here's that decubitus, right? It's the same concept. It's just instead of the air sitting behind the diaphragm, it now has risen up and it's sitting between the liver and the thorax and the abdominal wall. Okay? It's the same concept. Same concept as doing that, the hydrothorax, right? Or pleural effusions. Same aspect. Peptic ulcer is still the most common cause. Extraperitoneal air. Most likely going to be seen on CT, difficult to be seen on X-ray. Okay, I'll show you what it looks like on X-ray in the next slide. But you end up having air in this kind of like mottled, blotchy, patchy kind of appearance, right? It doesn't really move with patient positioning very much. So this is not going to rise up because it's extraperitoneal, so like retroperitoneal, it's in the back area. Diaphragm's up in the front area. This is in the back area, so it's not going to rise up underneath that diaphragm really well. The key thing with this one is a lot of times you'll see your psoas muscle really well. Okay, you can sometimes see your kidneys pretty well. It can also be produced right here through a pneumomediastinum or pneumoperitoneum. from a diaphragm hiatus, so if like there's a hole in the diaphragm, it can be created that way as well. So, streaky linear appearance in the extraperitoneal space, you can see it there on the CT, and then here on the X-ray, right? Look at all of this air, and look at how it doesn't look like it's within a bowel, right? Like everything else we've looked at in the abdomen that's had the air, you can kind of make out an ovalish, circulish, tubular kind of shape that air is in. This just looks like it's kind of scattered throughout, right? Just kind of scattered throughout the abdomen. I have this nice like little air line kind of along the edge here between the liver and the edge of the thorax and the abdomen there. I got some of that. So that's going to be your extraperitoneal. It's got the psoas muscles here. I don't want you to marry yourself to that because in your skinny, like fit patients, you're going to see the psoas muscles quite well on X-ray. But that's your extraperitoneal air. Usually your blunt penetrating trauma. The biggest difference is look at what the air is not doing. It's not rising. And whether I did this supine or upright, it's going to look the same. It's going to look the same. Pneumatosis, air in the bowel wall. This is what I was talking about. See how I can draw the bowel wall around the whole thing, and I end up having some radiolucence on both sides of it, right? I got air inside and outside. So I can make out that bowel wall through all of this area. You should not be able to do that. We should have air, bowel wall, and this should all be together out here in the same area. This is common in kids, okay? But you see that black line that parallels the bowel lumen, all right? Difficult to see sometimes, but we see it in kids more often than not. The change in appearance, much like the other rectal peritoneal air, it doesn't really change. Standing, supine, it's within the bowel wall, so it's going to kind of stay right in that area. So it makes that out. So that's your pneumatosis. FYI, right? You'll get this more, I think, in peds and probably GI, right? But you can end up having like necrotizing enterocolitis in infants, ischemic bowel disease in adults. You end up getting this like weird kind of mottled appearance. I don't even need to really draw it out. The white arrows kind of show it, right? That needs to be addressed. Hirschsprung's or pyloric stenosis in children is kind of one kids are concerned about. Again, you will learn that in peds and GI. I'm not going to test you on it, but when you get there and you happen to see a CT image with like that kind of air, that's what this is. Pneumobilia, air in the biliary tree. Remember how we talked about the air bronchogram, right, from the chest? Same concept here, only look in the liver section. I can see the biliary tree. It's more radiolucent. I can map it out. I shouldn't be able to do that. I can. Here's the catch with this one. This may not be abnormal. This might not be abnormal. What kind of question do you need to ask the patient if you see this? Have you recently had surgery involving the right upper quadrant? Did they recently take out your gallbladder? Did they recently do an ERCP? Did they do a procedure in that area where I would expect there to be some error possibly in there? Right? If so, then I'm not worried about this. For now, I will want them to follow up because this should be absorbed and go away. This particular patient, bless you, you can see the surgical clips. So this is not necessarily abnormal for them. It's an abnormal finding, but it's expected based off of the procedure that they recently had. But if they haven't recently had a procedure in the right upper quadrant area, the biliary tree, this is something to be concerned about. This is where we see the things on pictures and we go, oh, I gotta ask some more questions. Let me figure this out real quick. Okay, here's some more, right? Got the big white circle on there showing you the white arrow is another one of those porcelain gallbladders. All right, but you can see the biliary tree, all the radiolucent lines sitting in here. All right, that's your pneumobilia. So maybe your sphincterability isn't working. Maybe you had a sphincterotomy, prior surgery, like any kind of prior biliary tree gallbladder surgery can cause it. Uncommonly, gallstone ileus or gas-forming pyogenic cholangitis. Don't worry about that, GI. That is a possible cause. But more common than not, it's going to be related to probably a prior surgery in that area, or some sphincter, incompetent sphincter ability. Those are gonna be your two main ones. Questions on the 4 different types of air, how to see them, how to visualize them, understand where they're at, that kind of thing. Okay. Fasten your seatbelts for this section, because a lot of these pictures are going to start looking the same. If they haven't yet, they probably have, they're about to. And there are things in this next section between both large and small bowel via patient history and physical exam findings and things like that that will help you distinguish between bowel obstruction or bowel ileus, because they're going to be very similar, okay? On x-ray, you will need to distinguish, is this small or large bowel? Or really, where's the offending agent starting? Because you're going to see large bowel stuff can cause small bowel abnormalities, because guess what? They just back up, right? And eventually they're going to cause small bowel issues as well. So from the imaging, you'll need to try to figure out, is this small or is this large bowel? Then based off of what I'm going to teach you through the slides, is this obstruction, is this ileus? Okay? All right. If we don't get through it today, that's okay. We'll pick it up on Monday. So, this is the first slide to break those things down for you. Peristalsis continues despite obstruction to push bowel distally. So, if I have something that is obstructing my bowel, it's a pathway problem, right? Think driving down the road. You're driving through San Antonio, right? Traffic hits at a standstill. What's going on? There's a huge accident blocking all the lanes. There's an obstruction. Nothing can get through. Does that stop traffic from trying to get through? No. The cars are still squeezing together, right? They're trying to take a frontage road. They're trying to move. They're trying to get together. Peristalsis is continuing. The bowel is continuing to squeeze to try to push the obstruction away. The problem is not with the bowel. The problem is with the thing that's in the bowel that's stopping things from moving. Okay? Which means you're going to have squeezing, cramping type pain. When you listen to the abdomen, you might hear hyperactive bowel sounds. You might hear almost like sounds like a wheeze, like a high-pitched squeal, because it's just trying to push, and the patient's going to be in this pain, right? Proximal to that obstruction, so I got the obstruction, right? It's trying to squeeze through. Proximal to it, I'm going to have dilated loops of bowel full of air. Why? What's the patient still doing? Swallowing, eating, drinking, breathing. Air is still getting into my GI tract, but it can't go anywhere. So everything proximal to it is going to be dilated with air. Okay, make sense so far? Distal to it, I have no air. Well, why? Well, because afterwards, in my large intestine, I have air, right? Where does the air come from? The air comes from the eating, the drinking, the swallowing, the bacteria from before the obstruction. But if I have a big obstruction there and I have nothing getting through, that air eventually is going to go away because that patient is going to pass that gas and then there's none. So I have no air distally because I have a big boulder in the way and nothing can get past it, not even air. You can still have some areas of air in the descending colon or the rectal sigmoid. You can still have some if you just happen to get the picture when the patient hasn't been that long yet, right? But eventually there will be no air distal to the obstruction. And that's where you'll be able to see that transition point. You won't be able to see what the obstruction is, but that transition point will be when it goes from dilated air loops of bowel to no air afterwards. Okay? Here are your symptoms: abdominal pain, distension, constipation, nausea, vomiting. Changes versus proximal or distal obstruction, but those are your basic obstruction pathophysiology. Okay? Now, we talked about that. Now we're going to talk about sometimes an ileus here in the next slide. So changes in bowel history are important, right? What else do you think with bowel history for an obstruction is the patient not gonna be doing? They're not gonna be passing anything. Not gonna be passing gas, not gonna be having bowel movements at all, because all that air is gone. So when's the last time you passed gas? When's the last time you had a bowel movement? How long has it been? Those are the questions you're asking if you're concerned about an obstruction. We'll look at the imaging here stuff in a second, right? When we get into the ileus and the small bowel, large bowel, we'll look at all these based on a picture. So just understand changes in bowel history are important. If I'm having an ileus, when we talk about it, you're gonna find out if it's not an obstruction, I'm still gonna be passing gas. I'm still gonna have some stool coming out because nothing's stopping it from going. Because what an ileus is an ileus is basically laziness of the bowel. Okay? An ileus is where the part of the bowel stops peristalsis. Stops peristalsis. It's not squeezing anymore at all. Okay? Nothing's gonna get through that area because it's not squeezing anymore. So nausea and vomiting, sometimes they're present, sometimes they're not. You're gonna have abdominal discomfort, but flatus and diarrhea may still be passing. I'm still passing stool, I'm still passing gas for an ileus. Whereas an obstruction, I'm likely not. Okay? You'll get an x-ray, that's when you're looking for localized versus adynamic. Adynamic is another word for generalized. Is it just in one area or is it the whole bowel? Right? Great. You're gonna get air fluid levels, you'll get dilated loops of bowel, we'll look at it. Localized ileus usually only affects the small bowel. Usually only affects the small bowel. Okay? Generalized ileus affects both. Localized small bowel, generalized or adynamic, right? Same, affects both. CT is your study of choice. Okay? You're gonna see dilated loops of bowel. You might be able to determine the underlying cause with the CT, and that's why we like it as a study of choice. I don't need it to diagnose an ileus. But if I have an ileus and it's due to pancreatitis, or cholecystitis, or some other itis or something that's going on in the bowel that's ticked it off to tell it to rest, the CT will tell me that. So that's why we get the CT. Not to actually like diagnose the ileus, is to possibly find the underlying cause. So the functional, right, the localized, it's one or more loops, they lose the ability, to propagate peristaltic waves. So when I'm doing my physical exam, what's different? Hypoactive bowel sounds. Because the bowel in that section is not peristalsing. Whereas with the obstruction, it's trying to squeeze the obstruction through. You're either gonna have normal active or hyperactive bowel sounds because it's just trying to push it through. In the ileus, it is stopped. So it's hypoactive bowel sounds, okay? Localized, one or two loops of bowel, maybe three, not very many, okay? Generalizes both the bowels. We'll take a look at what those look at. It's typically caused by irritation. Irritation and inflammation causes the bowel loops to just stop. It doesn't want to do anything anymore because it hurts. And it's tired of being inflamed and angry, so it stops peristalsing because it feels better if it doesn't peristalse. That's what an ileus is, okay? So functional ileus, yeah, it says it does not produce a degree of obstruction that mechanical obstruction does. Sure, don't get so hung up on that, right? Because mechanical obstruction, functional ileus means it's not moving. Maybe there's something in there that's causing it. Maybe there was some irritation from pressure or whatever. Focus on obstruction, what we talked about, and ileus, that the peristalsis isn't happening. Okay, so let's look at some pictures. 1 to 2 persistently dilated loops of small bowel. So now how do I know this is small bowel? Okay, step 1. It's all pretty centrally located, right? And I can't even say it's centrally located because I have organomegaly, because the spleen's not coming past the 12th rib, liver looks pretty good here, right? It looks like it's pretty centrally located. On top of that, I have multiple loops sitting on top of one another. Think about the small bowel, how it does that. It lays all over itself and on top of one another. Then, look at my valvula coniventes. See how these radio-opaque lines come all the way across and they're really close together? That is a sign of small bowel. That is a sign of small bowel. The valvular coniventes. I also have some air fluid lines, because this is a erect or upright abdomen. But really the biggest one is the fact that it's multiple loops on top of one another, and then the valvular coniventes. Those are the guys we're looking for. Okay? That's your functional ileus, localized ileus, right? Just a couple of loops. Your adynamic is both. So I got small bowel and large bowel involved here. Look at how large the bowel is compared to the other slide before, right? They're sitting on one another. I do have some valvular conventaes coming across kind of like here in this loop here, but then when I get to some of the other areas, I got the haustra, which is just like a little bit, right? Just like a little line right here. It doesn't go all the way across. That's what that haustra is showing me in that aspect. So, and you can't even really say, well, like, you know, this has got to be large because of that, because when this stuff dilates, everything gets pushed and moved all over. So you got to try to use your knowledge of like, what does it look like under imaging with the haustra versus the valvular conventaes and try to figure out which is which. Really, all you really need to do is figure out, is this both or is this just a small bowel? Okay? So where else? What was here? Elderly due to prolonged hospitalization. We'll talk about the most common reasons for ileus and obstruction and stuff like that here in just a second. Biggest thing too, no transition point. At what point do I have a bunch of air and then all of a sudden none? I don't really have anything. That's going to help you with an ileus as well, because you're still going to have gas in the rectosigmoid area. So if you look separately here, I still got some gas in that rectosigmoid area, whereas my obstruction, that gas is likely going to be gone, because that's the first gas to leave, right? And if I'm obstructed, nothing else is coming out behind it. Okay. We'll look at more pictures of this. Who likes charts? Here we go. This will help you distinguish between some of these things. Localized ileus or generalized ileus, or adynamic, same, right? How many do you usually have air in this area? What's going on? But then compared with the obstructions for small and large bowel. For small and large bowel, okay? So this is a chart for you to kind of review and help you know the normal, what you're looking for. Yeah, right? And so we turn around and I go, I give you this picture, right? And you're like, what the heck is going on here? First thing I need you to do is it's small or large bowel. There's a couple of hints on this, right? It is small. I have multiple loops of bowel all sitting on top of one another. On top of that, I got my valvular conventaes everywhere. Here. So I give you this and you go, boom, I know it's small bowel. So now you turn around and you go, is this an ileus or is this an obstruction? Now you need more information. Oh look, peristalsis continuing. There's high-pitched hyperactive bowel sounds. That's leading me towards obstruction. Distal to the obstruction, it emptied the small bowel and large bowel. You can't really tell on this one, but there's not a whole lot of air, right? But the biggest thing is, have you been passing gas? When's the last time you used the bathroom? Well, I haven't been passing gas. I normally do. That's a concern for an obstruction. Later on here in a little bit, actually coming up in the next slide, we're going to get to the most common causes of these things. And that becomes another history question, right? What have you been doing recently? What's going on? Oop, wrong button. Right? Have you recently had a surgery in the abdomen? Because post-surgical adhesions are the most common cause of a small bowel obstruction. Now what we're going to get to later is, yeah, I did. When? When? Because guess what the most common cause of an ileus is? Abdominal surgery. Great. How do I know, right? One of them, it's all timing. Post-surgical adhesions take months to cause an obstruction. So when was your surgery? If it was 6 months ago, 7 months ago, 8 months ago, small bowel obstruction. That's what's on my mind because it's been a while. Post-surgical adhesions take months to adhese and then cause the obstruction. But that is the most common cause of a small bowel obstruction. So, what a great second or third order question type thing if I were to give you the image and give you all the things that scream small bowel obstruction, but then ask you, what was the most common cause of this abnormality? Right? Shake your head all you want. I know, I get it. It is. That's how all your test questions are going to look like over there, right? That's how they're all going to look like, unfortunately. It's like, I know you can pull a small bowel obstruction, but do you know what caused it? Because sometimes all you might get is just that piece of information from the patient. I don't know. It's my way to test on that. So they won't all look like that, but there will be a lot more vignettes this time than last time. A lot more vignettes. So yes, all these other things on the chart can cause small bowel obstruction. Yes, absolutely. So it is not just surgery, right? But what would I do? If I saw this, I'm going, okay, hey, have you recently had an abdominal surgery? No. And I say recently, crud. Have you had abdominal surgery in the last year? No. Okay, well, there rolls out my most common cause. Well, I better know all these, so now I can start asking these other questions to figure out why the heck they have a small bowel obstruction. Because the picture says it, the physical exam says it. I'm confident in knowing I have hyperactive, like kind of like that squealing, painful, cramping bowel sounds and patient symptoms. So I'm confident this is a small bowel obstruction, but now I don't know why. So I got to start digging down all these things to figure out why, because I was really hoping she had surgery in the last year, but she didn't. Right? That's where this chart comes into play. Here's another one, a little less crazy, but still a small bowel obstruction, right? I have my stacked loops of small bowel. The other side is my valvular condimentes. Not as well noticed on this one, but they're still there. And then air fluid levels in all of my bowel. So, but look, I still have a little bit of air in the descending colon. Just means I haven't caught it, or I caught it earlier, right? Had I waited a little bit longer, that air would go away, because it would eventually pass, and it would go away. Okay? Got a surgical clip there, so that's helpful. But remember, so where is my transition point? Kind of hard to tell in the small bowel because of the way kind of the loops go. So, but I don't need to worry about a transition point in the small bowel because I can just say this is small bowel obstruction. How do I know it's just small bowel obstruction? I have no large bowel involvement. I have no dilation of my large bowel. So I know this obstruction had to have started in the small bowel because if it started in the large bowel and worked its way back, I would have both large and small bowel dilation. Right? Because proximal to the obstruction is where the loops dilate with air. Distally, they start to collapse once all that air and stool leaves. So I know this is just a small bowel and not a large bowel because of the fact I have no large bowel involvement. Does that track? Questions on the small bowel stuff? We will stop there for today. We'll get into large bowel obstruction tomorrow.